mynews.studio.
Picture this. On a quiet Gaza street, a vaccination team is weaving through rubble to reach hundreds of children. But it raises the question, can polio really be stopped everywhere?
Today is November 28, 2025. Let's dive in. Polio cases have dropped by more than 99% since 1988, right?
Exactly. Back in 1988, we were seeing about 350,000 cases every year across 125 countries. Fast forward to mid-September this year, just 28 wild polio virus cases worldwide. Vaccination has prevented more than 20 million cases of paralysis.
For some perspective, before vaccines in the 1950s, the U.S. alone saw over 15,000 people paralyzed every year. Most of them were kids under 5.
And it was often deadly. About 1 in every 200 infections led to paralysis, and among those, 5 to 10% died because of respiratory failure.
The Americas were certified polio-free in 1994. Then Europe and other regions followed. 2 out of 3 wild poliovirus strains are now gone, type 2 since 1999, and type 3 as recently as 2020.
Yet, wild poliovirus type 1 is still holding out in Pakistan and Afghanistan. In 2024, those 2 countries reported 99 confirmed cases.
And in 2025, so far, 188 cases globally. That's actually down from 562 in 2024 and way below the 1,253 cases seen in 2020.
But there's another issue. Circulating vaccine-derived poliovirus, or CVD-PV. These are mutated strains from the oral vaccine, and they can spark outbreaks where immunization rates are low.
Right. Since 2000, we've seen several thousand CVD-PV cases, mainly in places with low vaccine coverage. In just the last 2 years, outbreaks have even reached Gaza and 5 cities in Europe.
So, the real vulnerability isn't the vaccine itself, but how widely it's used. In the Americas, only 83% of children got their 3rd polio dose last year. The World Health Organization says we need 95% for herd immunity.
That leaves millions of kids unprotected, even in regions that are supposed to be polio-free.
Globally, it's even tougher where there's conflict or weak health systems. Northern Yemen and Somalia, for example, have large groups of children who haven't received any polio vaccine in over a year.
And the funding gap makes it worse. Back in January, the U.S. threatened to pull out of the WHO and almost cut USAID funding. That caused a $131 million shortfall for polio programs.
All this is happening when ongoing investment is crucial. Conflict in Afghanistan, Pakistan, and around the Lake Chad Basin means it's hard to reach children, especially as families move across borders.
In Gaza, vaccination campaigns took place during a humanitarian pause. Over 560,000 children were reached, and no new cases since. But the danger hasn't gone away.
Despite these obstacles, there's been adaptation. This year, the Global Polio Eradication Initiative launched a new plan, more localized, efficient operations to stretch limited resources further.
And vaccine technology has moved forward. The new oral polio vaccine 2, or NOPV2, introduced in 2021, is more genetically stable and less likely to turn dangerous.
So far, over 1.65 billion doses of NOPV2 have been given, and only about 30 outbreaks linked to it. That's a significant step up compared to earlier vaccines.
Surveillance is sharper, too. Wastewater and other environmental samples are tested. In Pakistan, 275 wild poliovirus-positive samples were found in 2025, down from 741 in 2024. That shows both ongoing transmission and the value of this monitoring.
But how are health teams tackling vaccine hesitancy and reaching under-immunized groups, especially where polio is still present?
It's a multi-pronged effort. Thousands of community health workers go door to door to build trust and answer questions. There are also extra immunization campaigns, sometimes across borders, and smarter surveillance to target where help is needed most.
And just to clarify, how do CVD-PV outbreaks differ from outbreaks of wild poliovirus?
Wild poliovirus is the original virus, now only in Afghanistan and Pakistan. CVD-PV actually comes from the oral vaccine, which can mutate in areas with low coverage. That means CVD-PV outbreaks can happen anywhere that vaccination drops off.
So even with the improved NOPV2 vaccine, if coverage is low, CVD-PV is still a risk. Stopping those outbreaks depends on reaching every community.
With funding under pressure, what kinds of new financing or partnership models are being tried?
Debt swaps, catalytic funding, and including polio into larger health budgets all are being used. There's also a strong move to make polio programs part of national health systems for long-term stability.
Regional partnerships matter too. Plus, combining polio vaccination with other health services can make each campaign go further.
Groups like Rotary International are still pushing for both political and financial backing, making sure polio stays a global priority.
The stakes are still very real. Just earlier this month, on November 11th, the WHO Emergency Committee called polio a public health emergency of international concern. Eradication, if achieved, could save $33 billion in health costs by the year 2100.
World Polio Day this year reminds us we're at a turning point. Only smallpox has ever been wiped out. Polio could be next, but only if we keep up the commitment and work together.
So the real question is, can we finish the job, or are setbacks going to undo decades of progress?
That's both the challenge and the hope.
Thanks for joining us as we explored how close the world is to ending polio, what stands in the way, and what it will take to finally get there.
Thank you for listening. This episode was brought to you by mynews.studio. Try it now for free.